Hi, good afternoon, everyone.
Good afternoon.
We are going to start in a couple of minutes. Just give a bit of time for the participants who would like to join to us today. We had plenty of registrations, so we will wait a couple of seconds and then we can start. People are still joining, so perfect. Yeah, and I think we can start maybe. So hi and welcome everyone. Good afternoon. It's really lovely to be here together today with an interesting topic of cancer and pain, challenges, solutions, and innovations. We will have approximately an hour to discuss this topic, and we will have two wonderful speakers who we will introduce quickly in a second. Today, webinar is organized by European Pain Federation and European Cancer Organization together. So very warm welcome to everyone. I am Zsófia and I will be the moderator today here. Hopefully yes. So we have two speakers, Patrice and Andrew. Welcome. Thank you for your time and thank you for being here. Please introduce yourself briefly. Patrice, could you please start?
Thank you. Thank you very much indeed for the invitation. I'm Patrice Forget, professor of anesthesia and pain medicine in the UK, in Aberdeen. And I'm also a board member of the European Pain Federation and the chair of the Social Impact of Pain platform that I will speak about in the context of pain and cancer. Thank you.
Thank you, Patrice. And Andrew.
Thank you. Hello, I'm Professor Andrew Davis. I'm Professor of Palliative Medicine at Trinity College Dublin, University College Dublin, on Our Lady's Hospice and Care Services in Dublin. And I'm here representing ECHO, the European Cancer Organization. I'm the co-chair of their Survivorship and Quality of Life Network. And again, I'll talk a little bit about that later on in this session.
Thank you so much. I just show you quickly the agenda of today's webinar. So we are in the welcome section, and then we will start with an EFIC and SIP introduction, and then the presentations are coming, and then in the end of this 1 hour, probably we will have a bit of time for questions and answers, so Q&A section. So feel free to put your questions already, meanwhile the presentations, and then we can actively discuss this topic. And now I think I will hopefully the slides cannot move forward, but oh, yes. So I will give you the chance again, Patrice, to quickly introduce the organizations and then to show your slides. Please let me know when I have to go forward.
Thank you. We do not see the slides yet, but or maybe that the people see the slide and I don't. Otherwise, I can anyway start explaining a little bit that during the next 15 minutes. Take your time, Sophia. Yes, it's coming. I will detail or explain a little bit why challenges are still there when we speak about cancer and pain. But fortunately, we have solutions, and then we can definitely innovate. And even if we hadn't any slide, that would be nice just to have a discussion, because it's definitely about you, what you can do, what we can do together. So feel free to come with a question and answer, and I will be as short as possible to let place for that. Next slide, please. Yes. So recently, when thinking about, and that's a little bit of my personal story in pain research, when thinking, oh yes, but we know that in acute pain we have found so many solutions that we shouldn't have any real challenge anymore. And in cancer, we know very well what the treatments are, and then it's just about implementing that. And in fact, we detailed in this correspondence in the Lancet that we still have so much to do. And as frontline workers, we know that people still continue to struggle. Fortunately, we have again solutions, but there are still many things that we need to improve in terms of access to high quality care, but also pain education and pain research. That's about educating patients, but that's also about educating professionals. And I will come back on that at the end of the presentation. Next slide, please. Just about the magnitude of the problem, and it's a complex equation because we've seen during the last few decades an increase in cancer incidence, also an increase in terms of prevalence because diseases may last much longer because a stabilized disease may let people with cancer as a chronic disease more than as in the past an acute one. And for some, we've seen a massive improvement in terms of survival. So that also tells us that people may live with the consequence of cancer treatment, differently managed and even cured, but with some potential adverse event or sequela. While in beside that, we still continue to see many patients, unfortunately, with an unfavorable evolution and with a quite short survival. These are not the last figures, so hopefully that some of these numbers are have improved in the meantime, but definitely just to show you that there is to some extent multiple variables changing at the same time, making all of us interested in improving pain care and quality of life in people living or having lived with cancer. Next slide, please.
Patrice, sorry for interrupting, but we just got some feedbacks that your audio is not the best, so it's really difficult to understand what you are speaking. So could you please do something with your microphone? I think it's something with that. Oh, right now we can't hear you. So something happened.
This one might be the best one.
Yes, it's wonderful. Thank you.
Super.
Thank you.
Thank you so much for thank you so much for saying that, because it's just a question of choosing the right microphone, and that wasn't the case. Thank you. So briefly, incidence and prevalence of cancer have changed, but the figure changed as well. So more people live with a history of a cancer and then cancer treatment, while in the same time we still have to invest much with unresolved pain issues. And so I will go a little bit fast in the next few slides, just for the sake of time and to let place for questions. But definitely we do know that some of the treatment induce pain and let people with persistent pain. Next slide, please. So being a survivor may be accompanied with pain, and the example of chemotherapy-induced polyneuropathy is definitely something that's quite frequent. Next slide, please. And also the problem of pain, of progressing pain when the disease progresses. And then we touch more palliative care context. I won't speak too much about that because that's not my specialty, but my specialty is anyway dealing with a lot of symptoms as an anesthetist and as a pain specialist. So to some extent to palliate with symptoms. And that doesn't mean necessarily end of life care. Next slide, please. So we need to improve massively the quality of pain management. And what does it mean to people? That's again a complex equation because it's not just about tissue damage. It's not about biological things. It's about how do they how do these people cope with pain? What do they know? What are their beliefs? That might be right beliefs, wrong beliefs. Many beliefs are totally right, but maybe different than a professional's one, and we have to respond adequately to people need and what is acceptable to them. What are their goals? What does matter to them is different than for other people, and we have to try to push the walls and making it possible to better cope with pain, even if sometimes we cannot, of course, eliminate it. Next slide, please. And being responsive means also that it may change over time. People views may change, but even pain itself, pain characteristics may change. Pain can be permanent, hopefully sometimes can disappear. This study is a cohort study that we have done 1 year after breast cancer surgery, 2 years after breast cancer surgery, and you see in this Sankey diagram that it changes. For many patients, it changes. For, let's say, the majority of the people, it's not a constant phenomenon. Next slide, please. So we have to consider that it fluctuates, that the characteristics can change. This hierarchical clustering is just a scientific way to identify clusters of symptoms. And then we see that people suffering from pain clearly linked to surgery also suffer from pain related to polyneuropathy, and that can be because of the chemotherapy, or that can be because of a pre-existing condition. And sometimes people with no pain initially later on can have a pain developing, typically because time course may also incorporate some aspect like adjuvant chemotherapy later on. And we do not have to neglect also the fact that it's quite complex because musculoskeletal pain, headache, are other issues. People with a history of cancer do not have the same life than before the cancer, so they may have more difficulties to cope with any kind of pain. Next slide, please. So the characteristics of pain, where it is, can change. That's exactly what I said regarding the permanence or the or how intermittent pain is. Next slide, please. And so we have to accept this subjectivity in terms of pain. How do they live with pain? How people live with pain, but how do they describe pain and how do they cope with pain? Fortunately, to try to reduce as much as possible the subjectivity of the professional to document pain, then there are some, or there were recently new development in pain classification, and the ICD-11 has been a major a milestone regarding classification of pain, and there is a specific place to or way to document chronic cancer-related pain, which can be also related to a treatment. So helps correctly identify the nature and cause of pain in a cancer patient or cancer survivor. And that is really essential. Next slide, please. So to summarize this first part, pain is common, if not the most common symptom of cancer. So that's an issue, and still people struggle with pain, especially at the end of life, but not only. We need to improve pain treatment, and I'm sure that if you are attending today, that's because you're interested in, and just being interested is already improving the quality of cancer treatment, because that starts with assessing and reassessing and empowering patient. So that's essential, but then we have to spread the word, and that's why multi-professional approach is definitely helpful, because unfortunately inequality still persists and we have to reduce that. That's a major aspect of our whole. Next slide, please. So that was for the first part. The second won't be that long at all. It's just to insist first on this, so to detail a little bit better this the importance of screening, assessment, reviewing quality of pain management, and that goes through the ICD-11 classification. I will detail how you can use that classification easily. Next slide, please, because sometimes people are a little bit afraid, and then you will see that it's not that complicated. Why is it important? That's because best practices and research using pain as a quality indicator should be promoted. what we mean through that, and that's what the social impact of pain platform has promoted, is that we need better data. Patient organization and patients themselves need or expect from us to collect data for making it possible to benchmark, but also to acknowledge the existence of pain, the existence of quality of life issues, making it possible to better support them directly by delivering and funding care, but also supporting them better by um, um, getting the best standard for education and training. And that's extremely important if we speak about quality in cancer care and education. You see immediately that without data, it's impossible to really progress. Next slide, please. And there are solutions. This interspecialty cancer training program curriculum has been developed by ECHO. That has been a fantastic progress. Next slide, please. I will just show you that I was particularly happy to see that new items were entitled support the patient prior and during treatment, and that includes discuss assessment and management of pain through the cancer journey, including in vulnerable populations such as the frail elderly, adults with learning disability, and those at risk of substance use disorder or substance abuse disorder. So that's very important to raise awareness on this aspect and then making it more visible and then immediately uh, uh, better addressed just by paying attention. And then later on, we can, of course, speak about technical skills and how actually achieve that. But it's already excellent to have that clearly named. And manage survivorship also includes the discussion about patient-related outcome measures, and that includes symptoms and symptoms includes, of course, quality of life measures and pain. So that's when pain is a symptom, but also considering in the paragraph before when pain can become disease on its own because chronic pain unfortunately can progress. Next slide, please. So ICD-11, to reassure you, this complex study done by Antonia Bark's team just shows that it's easier. So it's just a chart to show that between ICD-10, which was definitely a classification used by professionals of coding, ICD-11 can be used by any of us and can be used as classification for teaching different diagnosis. So in education, ICD-11 is useful, but also just communicating with the general practitioner, with all other professionals, and with the patient directly. What is the actual diagnosis we are speaking about? Next slide, please. And in research, so for instance, in my research program, in the PANDAS research program, then we have used the ICD-11 classification. And you see that it's not very complicated. It's just in chronic pain, a list of diagnoses and short definitions. Next slide, please. How to use ICD-11? You just type in any browser ICD-11, and usually this website comes first, and then you have the first choice on the left column, use ICD-11, ICD-11 browser, and then you can just type the diagnosis and quickly navigate to try to find the right taxonomy. Next slide, please. If you want to go further, if you want to disseminate, if you want to discuss that with other stakeholders, you can go to the Social Impact of Pain website, and you can see these endorsed white papers regarding all the recommendations and the details. Next slide, please. So then that can be used for organizing activities and things like that. With patients, we went back to the press and we published this press release when we were very happy to see that it was not only a noble intention, but it was also actually recommended by the EU Commission for being integrated and being the official taxonomy of the European health data space. So reaching the target we were looking for and patients were looking for. Next slide, please. And we describe that in next slide, please. In this letter to responding to the last ESMO guidelines for managing. Yeah, thank you for managing. I expected a title, in fact, and that's why I was looking for the other slide, but that's not an issue. Responding to the ESMO guidelines, so the clinical practice guidelines, we highlighted the fact that clearly ICD-11 might be a nice complement, making it possible to integrate and to properly document pain and consider it as a quality indicator, not because a score is necessary to or to give a definition of pain or pain management quality. That's not what I mean. What I mean is that integrating pain assessment and documentation on its own is a quality indicator. Next slide, please. And that's the last one. So it's just to thank because Interact Europe, thanks to ECHO, has been, I think, quite a major progress in this multidisciplinary vision. There is also in terms of patient-reported outcome measures and quality of life, the smart care, which has been also a very nice development. Thank you very much indeed. I think that it's definitely enough. And I will let Andrew go further and maybe Sophia introduce him.
Thank you so much, Patrice. Thank you. And then we are moving forward. And Andrew, the floor, I think, is yours from now. Yeah, can you hear and see and see the sharing?
I can. If you could move forward, please.
Perfect. Perfect. Thank you.
Okay. So as I said in my introduction, I'm a palliative medicine physician, professor of palliative medicine, and I think that's why I was chosen to sort of take part in this webinar, because I treat a lot of patients with cancer pain, mainly patients with metastatic disease, patients with advanced disease, but increasingly seeing so-called cancer survivors. And again, as I said in the introduction, I'm the co-chair of the Survivorship and Quality of Life Network at ECHO. Next slide, please. So what is ECHO? What's the European Cancer Organization? Well, as you can see on this slide, it's an organization that's made up of a number of professional member societies, 42, predominantly European, some international, and also 21 advocacy groups. And so these are all entities that are involved to a greater or lesser degree in the care of patients with cancer, and EFIC is part of the European Cancer Organization. And you can see here the sort of mission and purpose of the European Cancer Organization. Next slide, please. And these are some of our patient advisory committee. As you can see, they cover a wide range of cancer types, pediatric and adult tumors, and different systems, and obviously then specific tumor types, like for instance the Pancreatic Cancer Europe group. So ECHO has involvement, interaction with a wide variety of professional and patient-related organizations across Europe, and actively engage with the European Commission on all matters relating to cancer, including the treatment of cancer pain. Next slide, please. So we're split up into networks, and you can see here the different networks. As I said, I am part of the Survivorship and Quality of Life Network. So although there's a lot of overlap between these networks, we do tend to focus, particularly in our network, on issues relating to survivorship, and we don't define survivorship specifically, but we sort of cover all aspects of the cancer journey, really, particularly patients who are living with cancer, living through cancer, and living beyond cancer. And very much interested in quality of life, which includes symptom control and obviously pain control. Next slide, please. And these are just some of the more recent documents that the network have been involved in. Next slide, please. And particularly in terms of the Free From Cancer, these are some of the sort of areas that we're focusing on, trying to ensure that the commissioners, and particularly the European Commission, but commissioners in the sort of individual European countries sort of, are addressing these issues. And again, as you can see right there in the middle, pain features very highly in what we do and in our documents and in our communications. Next slide. So I'm going to talk a little bit about really what I do and what I'm trying to bring to our network. And I think some of the things I'm going to say are going to echo what Patrice has already said. But I think one of the issues that we have is that things are changing, that there are more long-term cancer survivors. The sort of problems these patients are seeing, are experiencing, are somewhat different to maybe what we have been managing in the past. And I think it's really important that we understand our limitations and that we increase our knowledge and our training, as Patrice has already said, so that we can give the best management to these people, particularly, I say, the longer term survivors. And I think what's really important to reiterate is that cancer pain is different from non-malignant pain in lots of ways. And very importantly, acute pain, which is the sort of pain that maybe most healthcare professionals are relatively comfortable about managing, is very different from chronic pain. And I'll come back to that a little bit later in the talk. And I think, again, Patrice talked about assessment. A lot of the patients that we see with chronic pain, the pain is related to neuropathic or mixed pain, so damage to peripheral central nervous system. And how you manage that is very different from sort of acute nociceptive pain. And so there is a need for better education of healthcare professionals. And I think the figures that Patrice has shown about uncontrolled cancer pain at different stages of the journey reflect the fact that maybe we've been too simplistic in the way that we've tried to manage cancer pain in the past, and we need to up our game, just like the oncologists have upped their game in terms of defining the sort of biology of the tumor and giving targeted treatments. Then we need to do the same in terms of pain. Next slide, please. If you can go forward. So and the next one. So these are all red cars, and this is my analogy of pain. So they all do the same sort of thing. They all will get you from A to B, and they're all red and they're all cars, but they're all very different. And depending on what you want, whether you want a classic Mini that will break down very easily, but looks really good when you're driving around, or you want a souped up Mini Cooper, a new electric Mini, which is very fast and very nice to drive, or whether you want an Aston Martin Vantage, which is very, very nice to drive. They're all red cars. They all do some of the same things, but they're all very different. And for instance, the one on the right is a hell of a lot more expensive than the ones on the left. But the reason for putting that up is to say that cancer pain is very different. Even cancer-induced peripheral neuropathy is very different from one person to another. There isn't a one-size-fits-all. Next slide, please. And I wanted to again reiterate what Patrice said about assessment is really important. If we don't assess patients properly, if we don't find out what is actually going on, then we're never going to manage their pain. Next slide. And again, Patrice has sort of talked about this. You know, we need to understand, is this an isolated problem? You know, or is this part of some sort of symptom cluster? And what does the pain mean? Yes, the patient, you know, may have had cancer treatment, and this may be ongoing pain, may be related to their previous treatment, may be related to their surgery or their chemotherapy that they've had. But maybe their cancer has recurred, or they've developed a second primary. Or most people with cancer are older and have multiple comorbidities. So is the pain actually nothing to do with their cancer or their previous cancer treatment? So a lot of patients that I get sent to see for a second opinion with, you know, difficult to control cancer pain actually don't have cancer pain. They have, you know, pain related to degenerative diseases or a completely different underlying etiology. Next slide, please. And again, as I've sort of alluded to, you know, we need to understand, you know, what is the underlying mechanism and what are the things that are driving the pain. You know, we all know about the fact that pain is, you know, a multidimensional symptom, and how things like particularly psychological factors can influence how patients experience that pain and how they respond to treatment. And it's really important that, you know, we assess patients for these things, because, you know, if somebody has an underlying depression and you don't manage the depression as well as the pain, then the pain is generally not going to improve. Next slide, please. Okay, so I wanted to throw out a few things over the next few slides about how maybe we should be thinking as things are evolving, as we're seeing more and more patients with chronic pain related to their treatment. Are there other things that we should be thinking about? And one of the things that maybe we should be thinking more about is prevention. Next slide, please. So I want to talk very briefly about chronotherapy. So chronotherapy is about giving treatment, whatever that may be, and generally most of the studies that have been published have been around chemotherapy. It's about giving the treatment at a specific time of day to either improve the efficacy of the treatment or reduce the toxicity of the treatment. And there is good evidence out there that actually you can particularly reduce the toxicity of treatment by just altering whether you give treatments in the morning or the evening. And for instance, there are studies looking at, for instance, irinotecan, and how, particularly in women, that if you give the drug in the afternoon as opposed to in the morning, the levels of potentially life-threatening toxicity, i.e. neutropenia, is much lower in the afternoon. So by just simply giving the treatments at different times, we may be able to reduce complications such as peripheral neuropathy. Although this concept has been around for a long time, much more research needs to be done. But we also know that the timing of surgery can affect complications, the timing of radiotherapy can affect complications, the timing of immunotherapy can affect the level of complications. So this may be one way of, in the longer term, reducing some of the problems we see in terms of chronic pain. Next slide. There may be other ways. At the moment, people are looking at whether cryotherapy during chemotherapy may be a method of reducing chemotherapy-induced peripheral neuropathy. So this is the same sort of rationale as using cryotherapy to prevent chemotherapy-induced alopecia. That seems to be in some treatment regimens of fairly effective treatment for reducing alopecia. Whether it'll be effective for chemotherapy-induced peripheral neuropathy, still need to wait for the results of studies. But again, it's always better to prevent rather than treat, because we know how difficult it is to treat established chemotherapy-induced peripheral neuropathy. Next slide. And the reason why we should look at things like prevention is because actually drugs don't work, particularly for chronic pain. This is one of the senior managers at GlaxoSmithKline who got into a lot of trouble when this quote was published in the national press in the UK. I mean, what he was saying was the truth, that, you know, a lot of patients, the drugs do not work. It didn't do very much for the share price of the company at the time. Next slide. But we know with drug treatment that when patients move from acute to chronic pain, that there's this shift in balance between the benefits of analgesics and the risks. So long-term treatment with whatever analgesic you care to think about is associated with greater risks. You know, we don't want to give long-term non-steroidal anti-inflammatory drugs. We don't want to give long-term opioids. We need to think about, as I say, prevention and then other ways of managing this treatment. And I appreciate that in the chronic pain field, there has been a move away from drug therapy to sort of multimodal non-pharmacological interventions, including things like rehabilitation and psychological treatments. But, you know, the resources there those sort of resources to manage chronic pain are very limited, or they certainly are in the UK and Ireland, where most of my practice has been. Next slide, please. And one of the things that I think that we're only really starting to appreciate is, when I started in clinical practice a long time ago, you know, we didn't have problems with long-term survivors, and we weren't worried about the long-term effects of opioids. But we are now, and we have a lot of patients who get started on opioids when they're having active cancer treatment and remain on those drugs. And those drugs are not necessarily being very effective in terms of managing their pain, their ongoing pain. However, they are associated with lots of problems, including some potentially life-threatening problems, sleep disordered breathing, for instance. We're not really sure about, you know, what the long-term effects of opioids on the immune system are. So we need to look at different paradigms. We need to develop services that are based not on pharmacological interventions, or primarily based on pharmacological interventions. Next slide, please. And one thing that I also wanted to mention, and Patrice sort of alluded to this, about association between, he was talking about different types of pain, but what we know in cancer patients at all stages of their disease, including long-term survivors, is that they get abnormalities in their circadian rhythms. And one of the things that's particularly common is this rest activity rhythm. So in normal people, you spend your time in bed, asleep, lying there very peacefully, and less than about 2.5% of all movement occurs during sleep. And in this patient, this is a trace of their activity. So it's using an accelerometer that's placed on the wrist. And you can see that when they're in bed, which are the sort of gray bars, there's very little movement. When they're out of bed, they're actively moving. So the blue lines are the movement. So this would be from a patient or a person with a normal sort of circadian rhythm in rest activity. Next slide, please. This is a patient with cancer. This is actually somebody who's got metastatic colorectal cancer who's having chemotherapy. And you can see that there's much less of a differentiation between day and nighttime, between in bed and out of bed. And this is particularly common, as I said, at all stages of the disease. It gets more common as you get more advanced disease, but it's equally fairly common in cancer survivors. And why is this important? Next slide. Well, it's important because it's associated with worse symptoms and worse outcomes. So it's associated with a number of different symptoms, not just things like poor sleep and fatigue, but it's associated with worse pain. And a bit like earlier on when I was saying that if you have a person who's got pain and depression, if you don't manage their depression, then their pain is likely to persist. The same is true here. These patients have worse pain, worse disturbance in activities of daily living, and seem to be less responsive to analgesics. So what you need to do is you need to manage their if you like, underlying altered physiology, as well as managing the pain. Next slide, please. And we've been doing some initial work in patients with advanced cancer to see whether we can reverse those abnormal circadian rhythms. And by using some very simple interventions, non-pharmacological interventions, so bright light therapy, cognitive behavioral therapy for insomnia, which is an online course that could be accessed very easily. And exercise, basically just encouraging the patients to walk a bit more. This is not going down the gym and lifting twice your body weight or running on a treadmill. Then we've managed to reverse some of those abnormalities. And as a result, improve patients' symptoms, including their pain, improve their quality of life. So this is looking at more than just the one symptom of pain. This is looking at the whole person and trying to identify, apart from damage to the nerves as a result of the chemotherapy, what else is going on? What is helping to maintain, drive the pain, and can we do something about it? Next slide, please. So yeah, just to finish, I think particularly chronic pain has been a bit of an orphan issue. It certainly has in my specialty and within oncology. I think there are inadequate resources out there. I think we need to look for additional interventions and some of the things that I've talked about in terms of prevention and management, I think are worth looking at again. But we need more research. And we need ongoing research because we're seeing new treatments and patients survive long-term with the complications from those treatments. So we know a bit about chemotherapy-induced peripheral neuropathy. What we don't know is what are the problems we're going to see with immunotherapy, with some of the targeted treatments down the road. And so we need to continue to do the research. And I think that's my last slide. Yeah.
Exactly. Thank you so much. Thank you, Andrew, for your presentation as well. And thank you for being with us. We have a Q&A section, and there were a couple of questions which were already answered by Patrice. And there are a couple of what we thought to answer live. I think, Patrice, you had some questions about EFIC Academy and the pain curricula and the cancer pain curricula there. Could you please answer it?
Absolutely. So triggered by a couple of questions about how to actually change the way pain is seen, assessed, and in particular neuropathic pain, because the management is totally different, the drugs are different, the time course is different as well. My short answer would be more education will definitely be the starting point. To better manage that, it's not only about education, it's also about implementation. That's a question which may have been from Felicia Cox, who's managing a number of education programs for EFIC, but also for nurses, pain specialists. It's probably a rhetoric question because she does know that it's a lot of effort, and I would just agree with you, Felicia, that it's a lot of effort for everyone, and we need to continue to work on that. And maybe that Andrew will add something regarding education and how to make that multidisciplinary to be sure that everyone can be equipped to help and support patient better, including in other specialties. I don't know, Andrew, if you want to comment that.
Yeah, I think that's really important that, we have people in my specialty, have a lot of training about the use of drugs. But we have very little training about non-pharmacological interventions. And so I think it's vital that we have training so we understand what our colleagues are doing, so that we can better decide whether actually we shouldn't be using drugs, we should go down this route, whether that be non-pharmacological interventions or whether there's some sort of interventional techniques, nerve blocks, neurolysis, whatever it may be. I think unless we all know about all of the options, then how can we offer the patients the best treatment? I think the curricula, particularly the postgraduate curricula, have been too focused on, we're training palliative medicine physicians, so we'll teach them predominantly about the things that we think they should know about, rather than everything, all of the different modalities.
Right. And then to jump on another question, because of course we need to see the disciplines also cross-talking, and then the interventional pain management is an example of that. When should we go and see and speak together? Because all we know a lot, and sometimes we have less experience, and then going back to each other is definitely important. If some of you as attendees feel less experienced, then the EFIC Academy is definitely one of the education platforms. And jumping on this interventional pain management techniques, that's an online question. When interventions are indicated in cancer pain, opioid versus blocks, because it's a fair question. It's more invasive, but opioids are sometimes ineffective, and we know that well. So it's much about the evidence, and the evidence is about education. So being educated and trying to know what's the best evidence in a particular field in terms of effectiveness. So the chance that the treatment will be effective, and effective for what? That's the second part of my answer, is that pain is not only about intensity, but that's all about functional interference and psychological distress. Finally, of course, about the adverse event and the side effects of a specific medication or treatment. But on a patient point of view, even if adverse events are, of course, important, we need to remember that pain is not only pain intensity, but also functional interference and psychological distress and coping. And again, as Andrew said, it's not only about medication or treatment, pharmacological or interventional treatment, but it's also about understanding what does it mean to people, what they would like to do, or when pain is not acceptable, and is there a specific goal we can address with a medication? Could be anti-neuropathic agent, for instance, for a neuropathic pain, or sometimes interventional pain management may be more effective than pharmacological treatment. And then considering that if we can reach the goals of the patient better, then it's good to offer the most effective strategy according to their views. I'm looking at the same time also to the other questions. Thank you for posting the links.
Yes.
And I just echo what Patrice has said. I think one of the issues is that with acute pain, we try and get rid of the pain. We try and reduce the intensity down to 0 out of 10. It's very different with chronic pain. And I think there needs to be a mindset change that we're not trying to get rid of the pain. If we get rid of the pain, great, but actually what we're trying to do is improve the patient's quality of life function. And it's really important to understand what it is that the patient wants. And to, you know, and often it's a balance. They want to improve their function, and it's a balance between improving their pain and not having the toxicity of treatment. So I think part of the education needs to be, you know, we're not trying to get rid of every last bit of pain in these chronic patients. And if we do, it's a bonus.
Thanks. Patrice, there are two other questions. I think that's what you mentioned before. Okay, in the webinar chat.
Yes, I'm looking at that to understand and see. In the meantime, it's great to see in the chat a lot of important resources, both EFIC, I mentioned the academy, but also from ECHO in the Interact program, and also very specific resources for people wishing to have a really comprehensive view on that. So yeah, the Eco Survivorship and Quality of Life Network and Women and Cancer Report, and but for the questions, so precision treatment approach, I do not know if this question refers to precision to yeah, a personalized cancer treatment and the consequence in pain, or precision medicine in cancer treatment, which may merit more than one webinar, because that's an exciting field of research. But now it's mostly complex, and probably that the truth we can approach best way for the moment in terms of precision is individualization and personalization by getting patient views first. So having an idea on the mechanism of the pain, so mechanism-based treatment, but having the patient views on that is probably the best way today to individualize management regarding risk-benefit balance. And the other question is more awareness on complexity of survivorship, pain, and symptoms. That's clear. Andrew has spoken a lot about sleep disturbances, which are unfortunately nearly constant in this context. But also then I see on the question interaction of pain treatment intervention with cancer-directed therapies. Is there going to be a comprehensive effort to address these issues scientifically? Has been definitely, so to answer this question, has been definitely considered as one of the priority in the last consensus paper published in January 2025 in the European Journal of Pain. It's definitely one of the research priority that a panel of experts defined. So the answer is yes, but even though of course it's not that simple, and we know that supporting research, especially in that field, is not always a priority for all the funding bodies, and we would definitely like to raise awareness on this issue. Thank you for the question.
Thank you so much for answering all these questions. I don't know if there is any Q&A. I cannot see any other questions. I think we have a couple of minutes left if someone wants to ask something about the presentations. There are also a couple of useful links, as Patrice said, in the webinar chat, so you can read more details about EFIC pain curricula and on these topics. People shared a couple of useful links, and I cannot see any more questions. So thank you so much for being with us. Sorry, I'm stopping the sharing. Thank you so much for being with us. Thank you, Andrew, and thank you, Patrice, for being here and for the great presentations and to answer all these questions. It's such an important topic, and I think it was wonderful how you shared all these with us. And thank you for our participants and the great questions. And you can find our webinars on the EFIC channel soon. So thank you and have a lovely day. Bye.
Thank you. Bye.
Bye, everyone.